Hi everyone, my name is Dr. Dean and I'm here with my friend
Venzel. Welcome back, guys.
Yeah, thanks for joining us today. And how far are you in your program?
Well, I'm at the beginning stages.
Yeah.
I'm at the beginning stages. Yep.
PT over here and maybe DC. We're still working on it.
And the midst of
right, and we'll do a shift, right? That's like a cut, like a, right? We're always talking about that direction change. So we're here today to talk about kinesiopathology in the blog and podcast series. This is article number 14, podcast number 14. And it's kinesiopathology combined with the story about gamma gain.
Yeah.
It's a little hard to demonstrate gamma gain because it's happening sort of in that proprioceptive myofascial layer, you know, you'd have to get out the microscope and stuff. So read the podcast or listen to the podcast, read the article number 14, and you'll get kind of caught up on gamma gain. So basically why we're doing this demo is that this article actually is about assessing for kinesiopathology. So what we're looking for are motor faults or motor mapping faults. So it isn't so much can the patient do something or can't they do something. The issue is how are they doing it?
Yeah.
What is the setup that they create? If you just say, I want you to do a forward lunge, okay, and they're like, well, how, you know, which leg, whatever, and you don't tell them, right? You say, I want 5 on each side. So you leave as much to them of the whole thing. So you don't demo, you don't talk them through it, right? You give them some parameters and then they have to figure it out, right? So this is actually one of the drills. We're going to show you 6 drills today. This six of the drills. I have more, it depends on what I'm assessing, but these are 6 like super classic. Anybody can do it in their office.
Yeah.
You know,
when you're 15, you're 30, eat lunch.
Right. And they're designed to be quick and give lots of information. But basically, you know, coaches could do this, conditioning trainers and coaches could do this. So it's not just something that's clinical diagnostic per se. So the design of these drills is to get as much information as possible from what you see. So, you know, you could put the patient in a leg press and, you know, but what are you going to get from that? You're just going to get, oh, how much weight can they move? How many times can they do it?
In a seated position.
Yeah, they're also in a seated position. Yeah. You might get, if it's a really good clinician, you might get them to get the patient to talk. Like, how do you feel? What's going on? Right? That's that feedback part. So when we're talking about kinesiopathology, we've talked about this before, we're talking about deficits and defects.
Yeah.
So the difference is deficits.
With deficits, they can be changed. Defects, usually you have them at birth or because of a traumatic injury. So
right.
That's the difference between deficits and defects.
Yeah, that's perfect. Okay, and so in kinesiopathology, what we're looking for is the ability to first plan and map.
Yeah.
So can you create, or can the patient, or look, we should include athletes, can you create in your head, can you kind of imagine, what is it I'm going to do? So that's that planning part, right? Maybe visualizing it or whatever. And then when we say map, we just really mean meaningful movement, right? Like following the intention of the drill.
Exactly.
Yeah, and don't get panicked when we use the word drill, because we're not, you know, we're
Drop
not.
down and give me 20.
Right. We mean a drill, we're just talking about a highly structured, specific movement pattern that we're looking for. So when we talk about planning and mapping, we're talking about 4 things. So they are?
With planning and mapping, we're looking at spinal stability.
Yep.
We're looking at core neutral.
Yep.
We're looking at proximal to distal.
Yes.
And then the accuracy of the motor mapping.
Right.
Yeah.
So how close are they getting to what we're looking for?
Exactly.
Okay, so and I think I already brought this up, this classic with especially with low back pain patients, or patients that don't have a lot of experience with movement. If I tell them, I want you to, let's say with the right leg, I want you to bring your heel to your butt by bending your knee, right? And so this is what they do.
Yep.
Now that's that, they're bringing their heel to, but I didn't allow for any movement in the hip. I didn't say anything about the hip, right? So what I'm looking for is this. So I'm looking for is just bending. Now you would be shocked, and we're going to talk about it, how many people can't do that.
Yeah.
Right? So that's what we're talking about, that we're talking about a fault response. So we're going to talk about this in the drills. So the point of the planning and the mapping is to assess like Venzel said, spinal stability, core neutral, proximal to distal sequencing, and then accuracy of the motor mapping. So when we talk about that, we're talking about, so let's say we've assessed them, right? And then now we're going to take them to this place where we're going to patient education, athlete education.
Yeah.
And so that's called, that sort of learning process, right? Practicing process. That's called soft wiring.
Yeah.
And then once they kind of get it, it becomes
hardwiring.
Right. Yeah. And when someone's like truly hardwired, you go from being the student
and being a teacher. So taking something from novel to known.
Yeah, novel to known. That's perfect. Good. So what we're looking at is assessing using a systems-based approach. We're not talking about how much strength do they have at the knee, how much range of motion do they have at the hip, right? How long, can you toe walk, right? Like we're not talking about. We're talking about. Remember, every drill is assessing spinal stability. What could matter more? The ability to find and manage core neutral. What could matter more? Being proximal to distal. So that's what we mean is that the core engages first before the limbs or any outer work happens. And then accuracy, right? So how inaccurate could, assessing knee strength be, right? So there's no spinal stability and there's no core neutral because they're usually sitting down.
And the perfect example is that would be like just lifting and going through a cycle. Like when I try to teach some of my athletes and some of my clients how to properly strike with their foot, you'll see these two major faulty responses. You'll see either the breaking, so now you're causing a lot of tension on the knee and the hip and the ankle that does not need to be there.
But it's automatic.
Yeah.
Unless you instruct, a lot of people will run in that break.
Yep.
Yeah, or they'll even break in the front of the foot. You ever seen somebody run and they kind of, like they're shoving their toes forward, so that's still breaking. And then what else?
And then shortening their stride by back kicking. So they think to go faster, they just need to move the foot quicker and then shorten up the stride, but now you're just wasting energy.
Right,
That's
and they really want to
pull. Yeah. So you want to be under your center of gravity when you strike the ground, because that's what propels you forward.
And less back here and more through here.
Exactly.
Yeah.
So as soon as you're under your center of gravity,
yeah.
You see, just doing that, I felt all the kinetic energy send you forward.
Okay, so this is important, and this may be new for some people, and this may not be. But listen, if you assess something and your patient or athlete or your client can't perform that exact assessment becomes the treatment in the treatment plan.
Yeah.
So you can't assess one thing like, okay, so, I don't want to pick on PT because, it might be your world, but I know you're going to improve it like beyond anyone's belief, right? So, but what I'm saying is if I assess the knee and let's say I use like a goniometer or whatever I'm doing, or I've got some little drill, my treatment plan can't be something else, completely different, and then reassess with the goniometer. The assessment is the treatment, right?
Yeah.
So what I'm saying is let's start with the first one, rhythmic stabilization. Okay, this is classic. Most people have already seen this. If you haven't seen this before and it's new, you're going to love it, and your patients are going to love it. Okay, so remember, it's a systems-based approach. I want to be able to assess the spinal stability, the core neutral, proximal to distal, right? All in one thing, right? And then the quality of the drill. Okay, so this is how this works. So the patient, so if he isn't in core neutral, nothing that I do matters. If I sit you in a chair and do this, it doesn't work.
Yeah.
Right? So he has to be in core neutral. Okay, so we say he's just standing, right? So he's going to have, it's 100% of his height. So he goes into core neutral, right? So, right. So let's show him again. Stand up and then core neutral. So you see there's a gap. So we say we have 100% of your strength at 80% of your height, right? Okay, so just turn to me a little bit so the folks can see here. I just noticed how great your shirt goes with our fancy rug. I just noticed there's like little spots. Anyway, all right, here we go. So he's going to come into core neutral. Now, this may or may not be known to the patient. If they don't know core neutral, you just tell them to get athletic ready. Whatever it is whatever it is, okay? All right, so this is the push-pull effect, okay? So I'm going to have my patient in core neutral, and I'm going to have them activate their core. I wouldn't be telling you that, though, right? Because I can't tell you anything, okay? All I'm going to do, so the purpose of the drill is I want you to resist, okay? So I'm going to put one hand in the front of the shoulder, one hand behind the back of the shoulder. This one's going to push, this one's going to pull, right? And push and pull, and push and pull. Push and pull, push and pull, push and pull, push and pull. That's 3. I'm going to do 5. 4, 4. Why am I doing 5? Right, so I want to see if it starts to fall apart, and then release. Okay. Now, I can't just use my judgment and say, well, was that successful or not? Because those aren't objective measurements for us, right? So now we're going to look at the fault patterns or the fault responses. Okay, so there are 3 with this one. Fault responses. The first one, let's show them. Okay. So one fault response would be that you just don't know what athletic ready is, right? So if you were just like, I just don't know, right? But then that becomes a treatment, right? Is teaching core neutral. Okay, so he happens to know core neutral. He comes into core neutral. Now, so the first fault response is I twist him and he doesn't come back to center, right? So he just goes with the flow, right? He just goes with the flow. He doesn't resist in any way, right? His core isn't activated, okay? So that's the first fault response that's possible. Now, when we get to some of the other drills like the squat, it's possible that they may have, because there are 10 parameters, they might have 5 or 6 or 2, right? So in this one, we're just looking at, right, were they soft and didn't cue in and didn't lock in their core to resist, right? Okay, so let's try it again. Core neutral. So the next one is he aggressively counter rotates. So I'm going to twist him here, and you're going to push really hard into here, right? And keep going. Yeah, he's like doing more work than I can resist, right? Release. Let's show him on the other side. So I get him in here. You see all that? Yeah, and then release. So you'll notice, let's do that one more time, this way. So you'll notice as he's coming around, see his knee and his hip is following into the rotation. So we want him to just stay pinned into the core neutral so he's not pulling around with his hips, right? Because this is just you being like, I don't want to say like frozen like a statue, but you're isometrically holding that position, okay? And then the next one, which is really curious, is you're going to actually, so I'm going to set up in core neutral, is I'm going to get my hands ready like this, and you're just going to, I'm not even going to do anything, right? So that's why we do 5. So let's say we do the first one, and you're like jelly, and just like, and he doesn't respond, right? And he doesn't respond. And he's like, he kind of gets it, and he's like, oh, I know what's going on, right? And now he like overly, the other way. You know, he overly responds, right? And he overly responds, and he overly responds, right? You're loading before I'm even giving you a stimulus. You're preloading, right? So you kind of get a sense that I'm going to start to push, and you counter rotate way too fast in the other direction. So those are the three basic ones, right? So we're looking at two parts: the preparation, right? What are you doing to prepare? You have your readiness and awareness, right? Which you're going to find with athletes more than with patients. And then what is the motor map execution? And in this case, this drill is amazing for that. You can really assess preparation and execution when there is an external load, right? So we're not looking at how strong is he, are his arms strong, are his glutes strong. We're not looking at strength, right? Because you don't ever need to assess someone's strength because it can be improved in a week. So who cares, right? So, but the interesting thing is with this drill, with this rotation, is that if you get a patient, like a low back pain patient, and you get them going on this, their pain starts to go away. And it's just one therapy drill. And there's no drugs, there's no epidural, there's no other medical intervention. So that's the number one, rhythmic stabilization. It's done 5 times, and it can be done at the hips, it can be done at the knee, it can be done at the elbow, the shoulders. There are other combinations that can be done, but this is, like I said, this is just an example, so the folks can see kind of what direction, and we can like deeply explain it. Okay, so we're going to take a break, and we're going to come back with the next drill. Okay, so we're back for the second one, which is trunk rotation. So trunk rotation is a lot like the rhythmic stabilization, but this has no external load. Right? So let's have you, why don't you be here and face the camera just a little bit more. Face your chest this way. Yeah. Okay, so trunk rotation is unloaded, so he's going to motor himself now through the range of motion. Okay, so I want you to start in core neutral, and then without moving your lower body. So I'm going to make sure I don't cue you specifically, right? Don't move your lower body. I want you to rotate your upper body to the left and right. So go to the right 5 times and to the left 5 times. So he's going to the right, to the right. Yeah, so look, his knee's not moving, his hip isn't moving. Good. And then you'll notice that his shoulder and his chest are moving as a unit, just not just the arms moving. Good, and that's a nice smooth movement. And then when he's done, just come on out. So that was perfect, really. Okay, so what we're looking for is not how far he goes, because it doesn't matter, right? The goniometer we kind of threw away, right? And if you read the article or listen to the podcast, you can see why we threw the goniometer and away. Okay, so what we're looking for is that, step back a little bit, is this, just really good accessibility into rotation, right? So it doesn't matter, I don't care how far I can go. So a lot of times when we're doing the therapy part, we'll grab, because we have a lot of Nike boxes. So this creates just like this arm placement, so you can get into the scaption of the shoulder. So this is the therapy part, right? And then see, what I want you to notice is that, here, I'm going to turn towards the camera. So when I turn, you'll notice that my shoulders are square with the box. So we're not looking for this, right? Or I don't want to turn and then just, my trunk is turned and then just keep moving that's not what we're looking for. So the box should be square into my chest the whole time. Sometimes I'll even have them do this. So now the arms can't, right, go out of the range into that fault move, in that fault part, that fault response, right, like that. Okay, so Let's talk about the assessment. Now remember we said before that the assessment would become
the treatment.
Right, the treatment, right? And so you could do this with the volleyball, you could do it with the basketball, you could do it with the foam roller.
Yeah.
I mean, it's kind of endless, but you must be standing.
Yeah.
Right? You can't, I know a lot of people like that thing where they lay down on the floor and they kind of stretch over like this, and that's great, but that's never going to be therapy because there's no core neutral. So let's talk about the fault responses, and here we have 4 with this one. So you're going to come into core neutral. Yeah. So the first one is when he turns, when he rotates, let's just rotate to the left there, his hip is going to follow, right? And then many times also the knee follows. So come back into neutral, let them see that again. Yeah. Now show them an example of the hip following but not the knee. So just the hip, right? So you can see that, yeah. And so what's happening to compensate is he's going into extension back here. Yeah, and then come back to neutral. Okay, so honestly, we break the hip diagnostically away from the knee. They kind of, they kind of do, right, come together. Okay, and then, you're going into that varus knee, right, valgum. Valgum, not varus, valgum. Okay, and then the last part, number 4, is what we already talked about with the box. So come into that core neutral. Okay, so now he's going to rotate to the left, and his arms are going to continue to go, but notice his chest doesn't. So then you start to see the movement here, right? But you're not seeing the rotation that you're looking for, right? So then the therapy would be like, honestly, I love using the box, or this 45 centimeter Swiss ball. Yeah. Okay, so come into core neutral. Yeah, so what I'm looking at is this should be square here, and he should be focused on the center of his chest here. So he should be able to follow me in the center. And then there's going to be a point where the chest just can't rotate anymore, right? Okay, and come back to neutral. So this is really good because, I mean, it's excellent. This is an excellent, amazing assessment. Yeah. To determine if the patient can understand a disassociated movement pattern. Yeah. So disassociated means that part of the body is mobile, right, and moving, and part of the body, I'm going to make up a new word, stabile. Right? Stable, yeah. So that's stable because it's not mobile, right? So I'm just going to make a point. It's stability, stability with an I. It's not stability. So it should be stabile. I just created a new word, so let's see. Stable. Right, if we can get everybody to use stable. Mobile, stabile, right? So disassociated, being able to do one thing while something else is not moving, right? So it's disassociated. And classically, in cardiac system, we divide it through the core. Primarily, right? So in this drill, the lower body is stabile, upper body is mobile. And so the question is, can the patient access, can they quiet here, not like stiffen like a rock, but can they quiet that, right? So then we're talking about that being more of a deficit than a defect, right? So somebody who's had lumbar surgery or fusion, right, now that's a defect.
And we can see how they're engaging that thoracolumbar fascia. So
right, exactly.
Yeah.
Exactly. So myofascial slings obviously are coming into play in a way that you can see, where in the rhythmic stabilization you can't, because they're completely locked in to place, right? So myofascial slings crossing from the top of the body to the bottom, and then from one side of the body to the other simultaneously, and also in the reverse direction. So not just from here to here, but also from here to here. So top down, bottom up, left, right, right, left, all simultaneously, and across both sides of the body at the same time, locking into that position, right? And then I'm just going to make a little side note here is when he's in that core neutral and we're doing this rhythmic stabilization, he's just perfect. I'm looking for what's called scaption. So scaption is this, if we just take like straight off of the back of him here, So this is about 30 degrees, right? So instead of you being exactly to the side, right, his humerus is about at 30 degrees here. And that is the perfect position for core neutral for the shoulder blade. So in that position, the muscles all around the shoulder blade are doing equal work to lock the shoulder in. Yeah. So, and then we were talking a little bit before about like people who get into their traps, right? Yeah. And then not talking about just being in the traps or whatever, but talking about it more as systems based, right? So yes, the traps and the lats and core neutral and spinal stability and proximal to distal. So those little features make sure that they're all integrated into that systems-based approach. Yeah. So we're looking for, like I said, planning and mapping, and then the 4 are?
Spinal stability, core neutrality, so pulling from the memory.
Yeah.
Core neutrality, and we're also pulling for the proximal to distal.
Yes.
And then the accuracy of the movement.
Right, of the mapping, yeah. That's exactly right.
Yeah.
Okay, so then we're talking about this sort of novel to known, or soft wiring to hard wiring, or from the student to the teacher concept. Great. Okay, so we're going to take a short break and then we'll pick up with number 3. Welcome back. So the next one we're going to do, number 3, is the buttocks kick. And this seems like it's kind of ridiculously simple, but honestly, I always use this with low back pain patients when they come into the office, part of my assessment. And also I wanted to make a point. These assessments, how much space are we using? Right? So anybody
4 or 5 feet,
anybody could use this, right? Okay, so basically I'm gonna tell the patient, okay, go ahead and start in the core neutral standing position. They may or may not know what that is, right? And then I want you to only bring your heel to your butt by bending your knee. Okay, and you're going to do that 5 times on each side. Now listen, it doesn't matter if you do 5 on 5 and 5, or you can go back and forth.
Okay.
Okay, so let's see what it looks like. Good. So you'll notice he's flexing his hip when he bends his knee. Yeah. Okay. All right. So you would have done 5 and 5. So this is what we're looking for. From core neutral, I want you to pull your heel back to your butt. And notice this is not, I'm not doing any flexion of any kind. Now listen, we have to give him some slack, because that's a classic runner's drill, right? That's a classic. Now listen, this kind of just came into my head. Now you're a runner, you've done it for a long time, but without external eyes, right? Let's say that's why that's developed into a faulty motor pattern, because you're using it in non-running scenarios. Right?
Yeah.
So we think about like regular folks becoming athletes and learning all these new drills, all these new skills, all that specificity, right?
Yeah.
But then in real life scenarios, it may not be applicable.
Yeah.
Right? So they may not be able to remove that wiring. So it isn't a faulty movement pattern in your sport, but then, right, you say, by the way, like I have had like some hip and low back issues, right? So what I want you to do, right, is so follow like here. See if you can pull just your heel to your butt without pulling your knee forward. Yeah. So it is possible. Okay, now by comparison, how much harder are you working to do that than the first one?
A lot harder.
Yeah.
Yeah. A lot harder.
Now that looks super simple, but it's not. And all the time I get this, right? So they do the required 5 and 5, and then we say, okay, let's talk about it, right? Because we always do the breakdown after. We talk about the fault responses. I may not say it's a fault response, because that sounds like they're being bad.
Yeah.
Right? Say, this is what we're looking for. Okay? So I want you to pull back without this coming forward. So leave your knee where it was and just pull back. Like, okay, I can do that. And then do it again. Because it's so ingrained.
And you know what, too, I noticed, and why I did it was, and I felt it immediately because, you know, doing it so much, you start to get the clinical eye. I went into acceleration and deceleration quicker, just bringing the knee to the butt. So I had a point
Snap
to go right back versus going and kind of like posting. It looked more like a post versus going into
so if you just
yeah,
so that's true. That's true.
Yeah.
So the fault responses are, of course, the hip and the knee flexed together. Okay. Now, so this is another one, is that the foot plantar flexes, right? So I think in the instruction I do say to dorsiflex the foot, right? So when they pull up here and they point, right? Everybody wants to point back. So I'm trying to get them to keep the foot, right? So foot plantar flexes, and then they might lose their balance, right? Because you have to shift over to one side. Now, if I just stand here, I could do this all day long, but I'm not in core neutral, so I don't have spinal stability. So we've lost 2 of the 4 things, right, that we're assessing. Okay, and then, believe it or not, some patients or athletes will refuse to do the drill because they know it's going to cause them back pain. So that's a fault response, right? Because then you get no performance to assess whatsoever. So that becomes part of the treatment plan. So this is super great for teaching or assessing at, you know, the lower limb specifically. Remember, this isn't every drill that we do. The 6 drills we're showing you today are just a piece, you know, as a sample of some of the drills. Okay, so this is about specificity. Can you hone down on one specific thing, right? Just one specific thing. Leave everything else out and do one thing, right? Which is not the same as laying on a table and can you pull your knee to your chest, right?
Yeah.
Because we have spinal stability, we have proximal to distal, we have core neutrality, right? And we're looking for accuracy of movement. So all the things we're looking for are already built into that, like, systems-based drill.
Yeah.
And then it becomes the treatment plan. So this is also appraising, we could call it top-down corticospinal, or that gamma motor neuron, right? Okay, so that's number 3, and we're going to take another short break, and we're going to come back with number 4. All right, we're back, and we're going to be continuing with the assessments. Now, I just want to make a point that these 6 assessments are steered mostly towards low back.
Yeah.
I would probably use 2 or 3 or 4 or 5 different assessments, and then that's, you know, different than what would happen, you know, medically, we could say, clinically in the medical field. The patient would come in, they would lay down on the table, on the exam table, and classically it's straight leg raise. I don't know if you've seen that yet.
Yeah, I've seen that a lot. Yeah.
Yeah. So the idea is at some specific degree of the leg coming up is supposed to be able to speak about where the symptoms are, because it's stretching the nerve a certain way or whatever that is. So that's one way to do things, but in that example, I don't see any core neutral. The patient isn't doing a stick of anything, so that, you know, it's all completely passive, right? And then there's no core neutrality. I call that corpse-like examination. Sorry, right? Like, it's like you're examining the dead. Okay. But it's done, you know, it's the go-to in almost every clinical setting, right? Except mine. All right, so we're going to talk about number 4, the flat back fold. Okay, so let's switch places, and then I'm just going to do a quick. No, I'm not. You know why? Because you're not supposed to know what to do. So that's, you know, that's me wanting to help the folks who are watching us do this, right? Yeah. So, okay, so this is my patient, my athlete. So, okay, we're going to be doing a drill, assessing a drill, and it's called the flat back fold. So you can tell them what it's called. And what I want you to do is I want you to clasp your hands together behind your back. So you're going to interlock your fingers, okay? Now it's important that if they can't reach all the way back, right? Or they can't interlock their fingers, or they can't, it's okay. It's part of the test though, right? And we'll talk about that in a second, or the exam. Okay, so I want you to be in that position. I want you to be in your core neutral, whatever that is, and I want you to flex at the hip to 90 degrees. 90 degrees. Okay, so what does that look like? And that's about it. Yeah. Okay, so he's definitely, it looks like he's in core neutral. He's in the 120 degrees. And so there's a point about this, right? There's a point to the shoulders. Now, let's already look at fault responses. There are 7 of them. Number 1, downward gaze. So I may have forgotten to say to look up right now. So can you look up? Yeah, okay, so that's corrected. Okay, now, if, like I said before, if the patient can't reach behind their back just because there's like a girth problem, right? Or it could be because this is too tight, right? So I'm assessing shoulder mobility with this drill. Remember, this is systems based. We're not looking for one thing. I don't want to see if he has tight hamstrings by doing this drill, right? This is assessing the whole unit, the entire patient. Okay, now, if you fold down as far as you can, what does that look like? Yeah. So that's about 45, 50, maybe working on 60 degrees. Yeah, so what we're looking for is now can you round your back and bring this down more if you round it rather than flat?
Yeah.
Right, so that's see this curve here? Now that's what we're trying to avoid. Now see, he can get this lower if he rounded, right? So the issue is try to come back up into that, right? So we're talking about activation of the erectors here, right? And then spinal stability of that TL junction, right? All of that together. Okay, now what I want to know is, at any point, did he internally rotate his shoulders in order to be able to do the drill? So come on up a little bit and turn towards the folks a little bit. Yeah, so what I'm talking about is as he folds, bend your knees a little, as he folds down, the shoulders start to roll inward, right? And classically they roll in, and then you get the rounding back, and then sometimes they can get a little bit deeper into the position that we're looking for, okay? So that's another fault response. So like we said before, it could be one of the fault responses or a group of them, it could be all of them, or you may notice some other weird thing, like their foot might, twist out or something.
Yeah. And then I noticed, particularly when I did it the faulty response way, my knee, I'll have valgus knee. So
right.
My knee, it got me down there. It got me to that point, but completely faulty.
Right, and I didn't put that on my list, but I would probably add that, right? Yeah. Okay, so another fault response is as they start to come down from the neutral position, that the knees bend more.
Yep.
Right, the idea, the patient in their head is, if I bend my knees, my body comes down, but your chest isn't really coming down anymore, right? Okay, so, and then the ability to get to 90 degrees. So what we're looking for here is, with the flat back, being able to have the forward gaze, right? The hands stay interlocked, the shoulder heads are back, and I didn't add any depth with my knees. My knees are still in that same 120 degrees, hips are 120, right? and then the hips go to 0, which is 90 degrees, and the back is flat. TL junction is engaged, right? So that's what we're looking for. And then, of course, with certain drills, and this one specifically, you have to add in there that they may refuse to do it.
Yeah.
Because they
causes pain.
Or they expect pain, right? Yeah. So again, remember these drills are not intended to isolate, discover certain things. So the 4 components that absolutely have to be in there are not muscle strength and flexibility and active range of motion or whatever, right? We're talking about spinal stability,
core neutrality, proximal to distal, and then the accuracy of the movement pattern.
Right. Yeah. Being able to attain it. Okay, great. So I think we have 2 left, right?
Yeah.
So let's take another break, and we'll come back with the next drill. Okay, we're back for the 5th drill. Yeah. Like I said before, these are mostly for like if I had a back hip composite kind of complaint, right?
Okay, gotcha.
Not necessarily pain, but usually comes in the door as pain, right? Subthreshold microtrauma, all that story. Remember that? Yeah. Okay, so this drill is the assessment is called reverse gait step over.
Yeah.
Now, I ask the patient to do this or athlete to do this, and like, that's too complicated. It's too hard, right? Can't I just lay down on the table and have you do straight leg raise? Can't we assess it that way? Right, so remember that we're looking for the patient accountable contributors, right? Spinal stability, that's something the patient has to provide. Core neutral, that's something the patient has to provide. Proximal to distal sequencing, that's, right, motor mapping, they have to provide that. Right, and then accuracy of the movement. So when you're doing an assessment on your patient or your athlete, every part of the assessment has to be their responsibility.
Yeah.
Right? So I'm just saying, like, if we were doing shoulder or assessing your elbow, you damn well better be in core neutral and have spinal stability, because that contributes to assessing, right, and treatment here. I can't just have you sit down and tinker around with your elbow. Yeah. Because this elbow problem or the shoulder problem is a product of using it on a tennis court or on a volleyball court or in a swimming pool, right? Where on all of those have core neutral, all of those have spinal stability first, right? Okay, so when you assess, you can't remove the sport or the shape of the patient, the motor mapping the patient has, right, that contributed to the problem. Yeah. That makes sense, doesn't it? It's kind of a long-winded way of, right, but I'm just saying is that you don't have a patient coming in and everything about the patient's their history and their lifestyle and all that, right, has nothing to do with the assessment, has everything to do with the assessment. Okay, so let me try to talk you through this. Okay. You're going to start in the core neutral position. You're going to, so let me talk you through the whole thing, because part of this is you have to listen and remember. So I'm not going to say first do this and then do this and then do this and watch you do it and cue you through it. You have to remember what it is, because you have to be able to plan and map it all on your own without me helping you, okay? All right, so from core neutral, you're going to raise your right knee. We'll start on the right. We're going to do the drill 5 times on each time. And so honestly, I always just do 5 unless it's a special case. Okay? So you're going to raise your right knee up, and then I want you to turn your right knee down and lift your foot up. And then I want you to reach it around the back like you're stepping backwards over a hurdle. And I want you to land in a lunge. Okay? All right. Now it's not that, like, normally I have all the instructions like on an iPad, and I just read off the iPad, right? So they may say, can you say it again? That's totally fine. Then I say the same thing again. So we're kind of like going with the flow right now. But to be fair to the patient, every patient should receive the same instructions, right? Yeah. Okay, so show me what you got.
And then
okay, and let's do 5. Now it looks like a lot, like this is a tall order for a patient, right?
yeah.
But if they just can't do it, or they just are floundering with it, that becomes part of the treatment plan, right? It's possible that this drill is completely inaccessible. So watch how he's doing it. And then you want to notice in each of the 5, is he getting better at it? Or is it starting to fall apart, right? So we call that failure, not fatigue. Fatigue is running out of gas. Okay, so quickly the 7 points are stepping too narrow and losing balance. So what I mean is that they start here, right? Or the lunge finishes here and it's narrow and they lose balance, right? So part of it is being able to start here, and then when they finish, they land in a wide. So we're looking for landing and stability. We don't care if they can land narrow. We care about is they can land in stability.
Yeah.
Okay, so inability to internally rotate at any point in the drill. So from the core neutral position, coming up and flexing, and then turning in here, right? So this limb needs to be flat to the floor, and then I'm gonna pull it around. I'm gonna continue to pull it around, and I'm gonna land in my lunge, okay? So what we're talking about is from the core neutral position, snapping up, and then as they come around, notice that my knee is higher than my foot, right? Or they start here, they can do it, they can get this far, but then as they come back, it starts to fall apart, right? So they're looking for the ability to pull that all the way around to the back, okay? Now also, and I didn't pay 100% attention, but you know, being able to use the arms somehow. So if they just leave their arms down, then they're removing a part of their contribution to spinal stability and core neutral. So the arm should be somewhere, I mean, you know, actually it should be opposite, should be in the front, right? And then as I pull my leg around, my arms should shift so that now these opposites are in the front. Okay, also what you might notice is as they come up is that the knee goes valgus and or the foot pronates, right? So you would look for that. And then another one, which we're kind of practicing a little bit, but so the trick is when you step in from core neutral, you step in or lean in, you want to make sure that this hip actually lifts and stacks. So you're trying to put this hip under and lift this hip up on top, right? Up here. And that's going to give you what you're looking for here, right? So if they just lift the leg and don't attempt to stack, never going to be able to get there. But that's, now you're like, this is low back, right? Now we're assessing the hip. Right? Because isn't this the base, the floor of the spine and core, right? And then also, I think I already mentioned this, that at any point in the rotation, the foot is lower than the knee or the knee is higher than the foot as it comes around. So those are the 7 fault responses that we're looking for. Like I said, this drill, like I'm already a little out of breath.
Yeah, it was not easy. It's all those years of track and field that made me look as clean as I did, but no, that was intense. I had to be hyper focused.
Right, and like I said, this could be too much for someone, but don't give them something to hold on to, and this just becomes a stepwise approach to their therapy plan, right? So you just get them used to picking up their hip and learning how to internally rotate their leg, and then you kind of put it all together, right?
The assessment is the treatment.
And then it also becomes amazing for reevaluation. And in my office, with their permission, sometimes we'll record a secure device,
Yeah.
or like on their phone, what's going on.
Yep.
So, okay, so that's number 5, and then we're gonna take a short break, come back number 6, the squat. Okay, we're back, and this is the final demonstration. It's number 6 is the overhead squat.
Yeah.
And then just a quick reminder that, we're looking at that systems-based. We're not, like during the break, you were like, yeah, I felt this and this and this and this and this and this. And you're talking about a patient and talking about, oh, there are all these things, but it's like, we're not drilling to see how well they do the drill. We're looking to see how do they prepare for it? How do they deal with the things they can't do in real time?
Yeah.
Right? Your watch, it isn't like, can you do the squat? It's not that. You can see it in their eyes, right? You can see what they're struggling with. And then, all of that becomes part of the picture because you're observing, you're not just observing the result. You're looking at the process of what they're doing, right? Okay, overhead squat. So I'm going to tell you what the 10 things are that you have to remember to do during the squat. You're going to do 5 squats. Okay, and then those 10 pointers become assessment pointers for fault response, which then turn into 10 points for a treatment plan, right? It's highly integrative of the myofascial slings, right? The outer units, the outer unit, right? And there are many myofascial slings. Okay, so firstly, I want you, from core neutral, I want you to come into a squat. And the squat is going to be where your thigh is parallel to the floor. Okay, that's number 1. Number 2, your arms are straight over your head. Fingers and arms are pointed to the ceiling. Okay, notice I'm not showing him, right? Your gaze must stay forward and not go down, right? I want you to keep your chin up. That's part of your gaze staying up as well. I want you to keep your chest up, okay? And a couple other things I can't say, but your heels must remain on the floor. Okay, so we're looking for chest up, eyes up, chin up, arms up, thighs parallel to the floor. Okay, heels must be down. Okay.
Gotcha.
All right. So from core neutral, whatever that means to you. Good. Now he has to use his memory device now. Okay. Let's see the first one. Okay. Are you there?
Yeah.
Good. And then come up. And then I want you to do 2 more in this position. From the side. Yeah, no, it's good. That's good. Yeah, 2 more like that, just so they can see.
Gotcha.
Go. There's the neutral. Okay, and then you can see already something's changed, right? So this is why it's fair that they can do it a couple of times. And then whenever you're ready, you think everything's there. And then one more time from the side view.
Okay.
So that's good. So while he's in this position, notice what we're looking for here. Notice what we're looking for here. Notice what we're looking for here, here, here. Good. And then when you're done, come up. And then let's face the camera and do 2 more.
Okay.
So it seems fair to give you 5 chances, right? I'm not trying to fatigue you. I'm trying to give you 5 opportunities to learn
and create the shape
in real time,
shape.
right? Because that's fair to the patient. Okay, 2 more. Yeah, whenever you think you're done, come up. Some patients will get down there and they'll kind of wiggle around and try to fix things. Some will go down and come right back up. Good, so he's a little bit better with his arms now. His arms are lined up with his back. Okay, and then come on up. All right, so here are what we're looking for. You did a good job keeping your heels down. Okay, so classically the heels just pop right up off of the ground. Okay, so when we're talking about the depth, so I'm going to break this down into the pieces. So we're looking at the thigh being parallel with the floor. So we want to be down here.
Gotcha.
Yeah, okay. And then the arms should be overhead and the arm should be straight. Okay, I'm sorry, I have to look at my list. And then my gaze is obviously forward and my chin is up. Yep. So what I'm looking for by those features is that I have neutral neck.
Yeah.
And then you look at my back and tell me if it's neutral. Am I in severe extension?
It's perfectly neutral.
Okay,
Yep.
and then you're going to look at my knees and see if they're valgus.
Nope.
And then you're going to look at my feet and look if they're pronated.
Slightly to the right, but
okay.
Yeah.
And then I'm done, and I'm going to come up. I'm not going to do 4 more of those. But what I want you to, I've got a lot of practice, but what I want you to notice is I was kind of calm down there.
Yeah.
Because I know that space really, really well. Mm-hmm. Okay? So it isn't, can you go do the squat? Can you go down and come up, right? Can you do this? Who cares about the squat? We need to appraise the elements that make the squat such an amazing assessment.
Yeah.
Right? So myofascial slings, again, spinal stability, core neutrality, proximal to distal, and specificity. Right? I'm a little out of breath from that. And of course, my heels were set.
Yeah.
Now, this is what we get. Mm-hmm. It's either here. I get this all the time. Totally looking down.
Yeah.
Or it's here, right? Mm-hmm. Or it's on the way up, it's this, right? It's that the valgus knee and suprapronated feet. Or I get the arms are out here, like this, if they can stay up. Get every combination that there is. But the arms must be straight. Mm-hmm. The arms are straight and drop right down into that beautiful, beautiful squat. Mm-hmm. Right there. It's so nice. Right? Great. Okay, so key points of the whole series. Mm-hmm. Systems-based assessment. And we've said this a bunch of times. Yeah. The assessment becomes treatment pointers.
Exactly.
And reevaluation pointers.
Yep.
Okay, great. Thanks for joining us. Please contact us if you have any questions or if you want to see anything else about therapies. We've talked about maybe putting together some videos that have specific workouts or movement patterns that you're curious about. We just love to do what we do. All right, thanks very much, Dr. Dean.
Venzel, see you guys again.
Yeah, thanks so much.